بسم الله الرحمن الرحيم. نكمل محاضراتنا عن local anesthesia. We have a more important topic I discuss with you nowadays. The fundamentals of technique. What's the technique that you use for local anesthesia? Before we start technique, we have some important thing we discuss with you is the importance of a quiet, confident, and friendly manner toward all patients. So, physical comfort is also essential for cooperation of the patient and the ease of operation of the dental surgeon. A surgical technique must have comfort and not have any stress for the patient. So the patient should be seated in a semi-reclined position with back and legs supported and with head rest in the nape of the neck. This position of the patient become in a comfortable condition that we can deal with him with good manner. Most adult patients will respond to dental surgeon and offer to gain the patient his or her confidence, and so premedication will not be required for the administration of local anesthesia for a relatively simple procedure. حقيقة التكنيك of local anesthesia very simple. مو تحتاج إلى premedication مثل general anesthesia. فلهذا can give easily and can with a comfortable condition of the patient. We have many types of local anesthesia. The first one is topical or surface anesthesia that have not injectable anesthesia that giving to the surface of the mucosa or the skin. The first one is spray. The active ingredient is 10% lignocaine in hydrochloride. This is as a local anesthetic drug that used for simple technique, simple procedure for the skin, like removal of suture or give an one-stitch suturing, or we have a pus and discharge for the pus. Other one that have do as a local anesthesia is ethyl chloride. Ethyl chloride spray that have freeze the skin or mucosa that supply. So if push some spray of ethyl chloride, the skin or become freezing, so the nerve ain't not work, so can easily do work simple technique like drainage of pus due to the pus is acidic media, so the local anesthetic solution not work carefully. So by freezing this part of the skin or mucosa and punch the abscess or pus formation to drain this from the oral cavity. Other type of topical or surface anesthesia is ointment. We have 5% lidocaine hydrochloride or amitocaine and penozocaine is used as ointment for surface anesthesia for the skin or mucosa of the oral cavity. This can use it if use an injectable for anxious patient, so this reduce the pain when inject the needle. Other one in emulsion. This contains 2% lidocaine hydrochloride. This emulsion will reduce the gagging reflex if taken any impression to the patient. فلهذا يستعمل الأمليوجين كذلك الأوينتمنت في تقليل الgagging reflex عندما تأخذ impression for the patient خاصة in full denture and the soft tissue become less sensation after put the ointment or emulsion. Other type of the topical anesthesia or surface anesthesia is use jet injection. This syringe not need needle and discuss it in the lecture of the instrument that used one of the dental syringe is jet injection that push a small amount of local anesthesia for small area that have in the mucosa, and you can do your incision or simple technique for this patient. We have two types as injectable anesthesia. The first one is infiltration anesthesia, and second one is block anesthesia. The infiltration technique is that give anesthesia for nerve end only, not for the trunk or the branch of the nerve, for only the nerve end that have been anesthetized. This technique is very simple and widely used in the dental surgery. The type of infiltration, we have many types of infiltration. The first one is called sub-mucous injection. We inject the local anesthetic drug and local anesthetic solution beneath the mucosa. Sub means beneath mucosa, so it is beneath the mucosa. It is used for the parietal surface of the mucosa that have firmly attached to the periosteum, so use small drop of that local anesthetic solution beneath the mucosa and call it submucosal injection. Other type of infiltration, supraperiosteal. It is common procedure that used for all infiltration technique that inject the needle and is go until reach the periosteum. So the local anesthetic solution given in the above the periosteum, so-called supra mean above the periosteum of the bone. So when give it that have the local anesthetic solution can enter within the cortical plate and cancellous plate and reach to the nerve end of the tooth that have need to be doing your procedure as extraction or other dental procedure. This is the supraperiosteal injection and it is very common. حقيقة استعمالنا للsupraperiosteal injection كلش واسع وخاصة for maxilla. This figure shows how we give the supraperiosteal technique for the anterior part segment of the lower teeth. Other type of the infiltration technique is sub-periosteal injection. Sub beneath the periosteum. So when insert the needle within the mucosa and reach the periosteum must have a bubble penetrate the periosteum. So the amount of local anesthetic solution is beneath the periosteum. In starting of giving this, the patient may feel pain due to stripping of periosteum from the compact bone and give a local anesthetic solution and can enter through the cancellous bone to the apex of the root of the teeth that need to be extracted. هذه حقيقة عملية شوية مزعجة للمريض ولكن كمية الأنستيزيا نحتاجها قليلة لأنه أكثرية cancellous bone and not need a huge amount of local anesthetic solution. Other infiltration technique, intraosseous. We do a hole within the cortical bone and reach to the cancellous bone, and then the local anesthetic solution can enter and give him with the cancellous bone, so easily penetrate to the apex of the tooth. حقيقة هذا التكنيك هو ما حد يستعمله بس مذكور بالكتب، فلهذا احنا يجب ان نعرفه ونعرف شلون do it by doing an incision over the mucosa and do a drill hole in the periosteum, cortical bone, and then reach the cancellous bone, and then give a local anesthetic solution within this hole to do a local anesthesia for certain person. إذا استعمالها غير منطقي، لأنه إذا سوينا يحتاج إلى local anesthesia لعمل incision and drilling the bone، فالأفضل أنه نعطي Sub-Periodically or Supraperiosteal. Other technique of infiltration, Interceptal injection. We have interceptal bone that between each two teeth, or the tooth with multiple roots, that insert the needle within the periodontal ligament between the septum of the two teeth or the two roots, and give local anesthesia, so directly go to the apical region and give a local anesthetic solution and anesthesia the tooth that we wanted. We finish the infiltration technique. The other technique is regional or called block anesthesia. Regional mean that give a main trunk, so the region that's supplied by this trunk can be all anesthetized. A block, we have a blockage the impulse of main trunk, so wide area can be anesthetized. Like this figure, all three branches can be anesthetized when given the main trunk of the nerve. We have technique called periodontal ligament technique. This technique indication is pulp anesthesia of 1 to 2 teeth, situation in which region block are contraindication, aid in diagnosis of pulpal discomfort as an injective technique follow nerve block if partial anesthesia is present. حقيقة periodontal ligament هي من التكنيك اللي push the needle between in the periodontal space, so can diffuse to the apex of the tooth that we want to be anesthetized. If there are between two teeth, the apex of one or two teeth in the same time, only that I needed. حقيقة there are contraindications for periodontal ligament technique. First, infection or acute inflammation in the area of injection. Second, patient who require sensation for psychological comfort. حقيقة the psychology of patient is very important because it's painful, slight painful، خاصة إذا كانت periodontal ligament and the bone is completely formed on any destruction. The advantage of periodontal ligament technique is avoid anesthesia of lip tongue and other soft tissue, minimum dose of local anesthesia is required, rapid onset of profound palpal and soft tissue anesthesia, less traumatic than conventional block technique. حقيقة عدة advantage في periodontal ligament، وكذلك أكو disadvantage. This disadvantage: excessive pressure or rapid injection may break the glass cartridge. A special syringe may be required. Pressure syringe: excessive pressure can produce a focal space or area for spread of infection. لهذا احنا لما نعطي the periodontal ligament نعرف space very narrow, so we have excessive pressure that give a rapid injection if that goes outside of periodontal ligament, or the syringe cartridge may break if there are the very excessive pressure in ordinary dental syringe, here breech metallic aspirating type or non-aspirating syringe. Other technique is intrapalpal injection. If there are pulp exposed by badly carious teeth or broken teeth, we can directly give slight drop of local anesthesia within the pulp and only the tooth that need to be anesthetized in this technique. We have this two technique, infiltration technique or block technique, can do for the all teeth in upper and lower jaw. Now we slight anatomy about the upper jaw is the tooth that have upper permanent teeth that sit on maxilla, that know that maxilla is huge amount of cancellous and thin plate of cortical and compact bone that in the labial and the buccal bone of the alveolar process that have very simple give infiltration to the maxilla due to the huge amount of spongy bone. حقيقة spongy bone مثل الإسفنجة يمتص بسهولة ويدخل and do it as local anesthesia for maxilla. We have many techniques for each group of teeth. We divide the teeth to groups for anterior and maxilla, for premolar and for molar. For anterior of the permanent anterior teeth, that is for central, lateral, and canine, we give the infiltration technique and insert the needle parallel with the long axis of the tooth that need extracted, as seen in this figure. We have block injection for the inferior orbital technique. The infraorbital block injection can simply done it by the dentist when insert in the deep vestibule the long needle that between the canine and the premolar or between two premolar and go upward, and you can feel the infraorbital foramen by the second hand, and then can below or slightly within the foramen, and this is very important in infra block technique. This technique give mainly for infraorbital nerve that supply the mucosa of labial gingiva that have from central lateral canine and the labial mucosa of the upper lip. If slightly enter the bubble of the needle within the infraorbital canal can reach the local anesthesia for the anterior superior nerve. So all the anterior teeth from central, lateral, and canine can be anesthetized by this block injection. The second group is the premolar teeth. The infiltration technique for buccal side by put the needle within the deep vestibule with an angle of 45 degree or from 30 to 45 degree to be more posteriorly and within the slightly within the long axis and within the occlusal surface, and can give for first premolar or second premolar. The anesthesia of the molar teeth. We have more angulation can do for the needle within the long axis or with the occlusion. So is with the long axis or can do the 45 to 60 degree, and with the occlusal surface is 45 degree, and can give a local anesthesia for first, second, and third molar. The first molar is the only two tooth that have three branches of nerve innervation. We have three roots: the mesiobuccal, distobuccal, and the palatal. And you must give two branch buccally to the mesiobuccal that have a branch of the middle superior nerve, and distobuccal branch of posterior superior nerve. So we must anesthetize two nerve. Either we can put the needle distal to the second premolar and penetrate the mucus to give a local anesthesia for mesiobuccal root, and then from the beneath of the buccal groove and go posteriorly and give anesthesia for the distobuccal root. Now If finished giving anesthesia labially or buccally, we go from inner side of the oral cavity in the roof of the oral cavity. It has hard palate and soft palate. We know the innervation of the hard palate by nasopalatine for premaxilla and greater palatine for other part of the maxillary process of palatine bone and alveolar process and palatine process of maxilla. This can give anesthesia infiltration submucosally for H2 nerve, the palatine nerve or greater palatine nerve, as we have in that give anesthesia for palatal mucosa from the side of the tooth. If give the local anesthesia in the incisive foramen, so main trunk of nasopalatine can anesthetize, so all premaxilla from canine to canine be anesthesia. And if give the local anesthetic solution near the greater palatine orifice, the nasopalatine, greater palatine nerve can be anesthetized from the first premolar to the third molar and by a simple inter-arch within this teeth. For now, the mandible, lower jaw. The mandible, as you know, is more compact than cancellous. This consists from the body is horizontally its direction and the ramus is vertically in its direction. The body have two parts, alveolar process and palatine process. As we know, at the medial surface of the ramus can enter two nerves is the inferior nerve and lingual nerve. The inferior alveolar nerve within the medial surface of the mandible and go to the mandibular foramen and enter through the infraorbital canal that supply all teeth from the second premolar to the third molar. And at the between two roots of first and second premolar, there are a foramen, call it mental foramen. So at this foramen, the nerve can divide it two parts. First part that go outside of the inferior alveolar nerve and supply the gingival mucosa of anterior teeth and labial mucosa of lower lip. And the other branch is continue to supply the canine, premolar canine and the lateral central incisor. The second nerve go more medially within the infratemporal fossa and go to retromandibular space is medial to inferior alveolar nerve and go above the mylohyoid muscle between this muscle and the mucosa floor of mouth and supply the lingual gingiva from all teeth from central to the third molar and give go out as supply for floor of mouth and go anteriorly and go within the anterior two-thirds of the tongue that supply the sensation and special sense for this area of the tongue. So the buccal side of the from second premolar to third molar that supply by long buccal nerve that is a branch of anterior branch of the mandibular division of trigeminal nerve. So we have this course is that medially to the inferior alveolar nerve and go and cross the retromolar area and go to the supply the mucosa of the buccal mucosa and the gingiva of the second premolar to third molar. The most important technique that give for the as a local anesthesia is infraorbital nerve lock technique. To know this infra lock technique, you must know the pterygomandibular space. as anatomy of this eye. As you see in this figure, with a pterygomandibular space, that space is surrounded by anteriorly by the medial pterygoid muscle and posteriorly by the buccinator and the masseter muscle, and from the outside laterally from the ramus of the mandible. Inside there are the pterygomandibular raphe that have contained the infraorbital nerve, the lingual nerve, infraorbital artery, infraorbital vein. This area you must imagine it before doing any inferior nerve block. This figure shows transverse section of mandibular ramus at the level of just superior to the lingula. The R ramus, IN inferior nerve, AIV inferior vein, and inferior artery. We have sphenomandibular ligament and medial pterygoid muscle, buccinator, pterygomandibular raphe. We have superior constrictor muscle from above, and the tendon of temporalis muscle, and the lingula is the medial surface of the ramus. The needle is shown passing through the pterygomandibular space where it's directed to an area of bone just superior to lingua. This is a level at which an inferior nerve block should be administered in this side of the retropterygomandibular space, or raphe. The technique of inferior nerve block, we take the syringe and the needle is parallel with the lower occlusal surface between first and second premolar, and go more posteriorly until reach the retromandibular raphe. Medial to the raphe, we insert until reach the middle surface of the ramus above the lingula. When you feel this bone, don't give anesthesia. We slightly pull it and give anesthesia for inferior nerve, and then pull it and give anesthesia for lingual nerve. This figure shows how insert the syringe from opposite side of the mandible between first and second premolar and parallel to the lower occlusion, and enrich the pterygomandibular raphe that insert it until reach the bone, as you see in this figure. This figure shows the dramatically as the drawing for the lower jaw, and you can see all the set of the teeth, and can give the anesthesia between the first and second premolar and go to reach to the pterygomandibular space and give anesthesia for inferior nerve and for lingual nerve. This figure shows clinical for the patient how can put the needle. If you do this technique, you use the second hand, left hand, that have within the external oblique ridge, go posteriorly until reach the retromandibular space, and when the patient mouth is very widely, so stretch the pterygomandibular raphe. So if reach this, the needle you must insert in the middle of your finger and medially to the retromandibular raphe, pterygomandibular raphe. This shows the bone of the mandible, how insert the needle by this straight line to the above of the mandibular foramen above the lingula. Other nerve you must anesthetize or a long buccal nerve. We can use either infiltration or block. If use the infiltration, that give in the deep vestibule within the side of the tooth need to do work it. So by slide rope, that early the mucosa and the gingiva is beneath beside the tooth can be anesthetized. But if need more than one tooth, or if need for surgical operation for impacted third molar, we give long buccal nerve block. We know the course of the long buccal nerve is medial from the ramus and cross the retromolar space and go buccally to supply the gingiva on buccal side. So at the retromandibular region, we can insert distal to the third molar and can take anesthesia for long buccal nerve block. This figure shows the course of long buccal nerve that is medial after removal of the ramus and the part of the body. You can see that the long buccal is come from outside to enter the oral cavity within retromandibular space. Anesthesia for anterior teeth. We know in child or young adult until adolescent, the anterior teeth is cancellous bone is more than the block, and it is more than posterior teeth. So we can do infiltration technique for upper central, lower central, and lateral and canine till to the first premolar to the children or young adult, and can give it within the deep vestibule for anterior teeth, for central lateral canine, parallel to the long axis of the crown, and within deep vestibule can insert the needle and give local anesthetic solution for each tooth. And we have do this technique in the labial side, and we can give infiltration in the lingual side within the above slightly the floor of mouth, can give slight amount of local anesthetic solution to anesthetize the lingual gingiva. The other technique of block injection for mental nerve, the mental nerve block injection, we know the small amount of the anatomy of the mental foramen, that it is located within the body of the alveolar process and the ramus mandible. This foramen between the two apices of the first and second premolar, and the nerve that emerges from it, the mental nerve, that supply the labial gingiva, the labial mucosa. If the patient look forward from the pupil to the infraorbital foramen to the mental foramen in one line, so we can imagine this by drawing an imaginary line from the pupil and go downward for mental, so we know the site of mental nerve. After reflection of the lip and cheek, we insert by 30 degrees within the long axis of the first and second premolar and insert in deep vestibule more deeply until we reach the mental foramen. If the mental needle is within the mental foramen, can anesthesia not only mental nerve, the labial nerve is the end branch of mandibular, inferior ulnar nerve of mandibular division of trigeminal nerve. Thank you for your listening this lecture. Thank you for your listening. If any question, can give me later.